extremely honored to be here with you. I've spent the last day and a half here meeting with some folks in DGHI, and if you don't know this already, then let me just tell you, you're very lucky to be here and part of this wonderful institute that is doing a lot of things the right way. I've had a chance to take some notes while I've been here talking with some of the faculty here and hoping to bring some of the incredible ideas and priorities and expertise that you've developed here, and hopefully we can learn a few things back home where I'm from. As Melissa said, I am a pediatrician and a pediatric emergency medicine physician specifically, so I see patients in a children's hospital in the ER, but my scholarly activity is surrounding building capacity for the care of children in hospital settings, and also designing programs to train the next set of clinicians taking care of kids in low resource settings as well. And so the title of the talk that Melissa and I sort of talked about was how to rethink global health clinical training. And while I'm going to be talking about a pediatric program, I think some of the principles hopefully are relatable to other training programs as well. So of all the forms of inequality, injustice in healthcare is the most shocking and inhumane, is what Dr. King said. And I think those of us who work in healthcare can see why that is. But inequality and injustice where? And that's something I'd like to talk about. Now, some of you who are savvy might fill in with another quote from Dr. King that injustice anywhere is a threat to injustice everywhere, and I believe that. I really do. But there are certain realities to the practice of global health. There are logistical realities that exist, not to mention there are philosophical questions that have arisen and resulted in the evolution of definitions of what even global health means. The Consortium of Universities of Global Health has come up with a definition. This is one that many of you are potentially familiar with. It's long. It talks about study, research, and practice. It includes the principle of equity for all people. It talks about population-based prevention and also individual-level clinical care. But it's, I think, been difficult even for those of us who do this every day to wrap our minds around what exactly global health is. There was a recent editorial by Sebastian Taylor where he attempted to sort of readdress this again. He uses the term a powerful discursive construct, which I think sounds really academic-y, but it actually I think is true. It's a sort of a talking point. It's a discursive construct. My favorite definition of global health is this, which was a concept fabricated by developed countries to explain what is regular practice in developing nations. So really, global health is just healthcare to most people, right? But I think for us who live here, really I think what we're talking about is to what do we dedicate our expertise and our practice? We all have had opportunities to gain expertise, so what do we dedicate ourselves to? And what is it exactly that motivates us to do that? And what are the foundational principles that guide us as we go about trying to dedicate that expertise? And these are things that I come back to. I think it's important to have the conversation that, the discursive construct that we have. I think that's important. But even potentially more simplistically is, where do we work? And who do we work with? I think those are also foundational principles or questions when I think about what it is that we're doing in global health. Your director, Dr. Plow, has said the temptation is to think of global health as happening somewhere far away. But the reality is that vulnerable communities experience health disparities right here in Durham. And I think there's this idea, and there's some consensus growing, that the philosophical questions about what global health is must include a discussion about disparities. And I think that this philosophical question is important and it's critical. It's important that we have a common language to guide our priorities and strategy. But there are also real logistical questions about how you do global health. And they're important also to ask. Because unless things are dramatically different here in Durham than they are in Utah, there tends to be a lot of effort and energy in global health spent around searching for money to execute on all the good ideas that we have. Certainly it's something that I think about a lot and something we talk about a lot, grants and funding and foundations and things like that. But also, and I'm speaking now from a clinical standpoint since I'm a clinician and I'm involved in clinical training, what is it exactly that we're training our clinical trainees to do when they're done? I am the fellowship director for a Pediatric Global Health Fellowship, and I was just at a meeting in Philadelphia with other Pediatric Global Health Fellowship directors, and the first question we had was, okay, so what do our graduates do when they're done? What is exactly that they're going to do? The fellowship director at the Children's Hospital of Philadelphia reported that over their 10 years of training, about 50 to 60% of their graduates end up coming back to the United States and working in underserved populations here. That's a bit of a spoiler alert about where we're going in this talk, but there are unifying principles in global health that are just as relatable to health inequities here as they are other places. So what I want to talk about in specifics here is, in addition to these philosophical and logistical questions and difficulties that we think about, I want us to think beyond that they aren't just challenges, but actually these logistical questions in global health can actually be opportunities. Now, I literally grew up in a town that's called Bountiful. So I don't come, I mean, my father and mother were both public school teachers, so it wasn't like we were rolling in cash, but you know, I grew up in a town called Bountiful, and I think that sums it up really nicely. I grew up in Utah, went to medical school at the University of Utah, and then went on to do pediatric residency in New York City at Columbia. And after my residency, I took a job in Malawi in Southeast Africa. And I am actually sort of embarrassed to say, because it's not like there weren't disparities around me when I was growing up and even training and in med school in New York City. But I think, again, I'm a little embarrassed to say it wasn't until I was in Malawi where I really keyed into this idea of a social determinants framework, right? And this is a picture of my two sons who are much older and more smelly now. He's 14 and he's 12. And I worked in a hospital called Kamuzu Central Hospital. This is actually one of my current pediatric emergency fellows, Elizabeth Keating. But it was in this time frame where it really locked into me what social determinants of health were. And I spent a couple of years there and came back to Utah to do a pediatric emergency fellowship, and it sort of changed the way I thought about healthcare delivery and taking care of patients. In Utah, we have a lot of things going for us. I don't know if has anybody ever been to Utah? Sure. Okay, yeah, so it's a beautiful place. We got a lot of things going for us. And it helps us recruit good people, actually. And in the healthcare sphere, we actually have a lot of really great things going on, too. But one thing that we're not very good at is providing primary care. So Utah is actually ranks 49th out of all states in PCPs per 100,000 residents. You know, our PCPs are getting older. And we need more physicians. So we're not doing very good at this. And this is particularly programmatic, given that in rural and frontier areas, patients are poorer and they get more sick. And Utah has a lot of rural and frontier areas. And rurality is associated with poverty, and it's particularly true in our region in the West and in the South. This is something that you guys see as well. Despite this, only about 2.5% of MD graduates intend to practice in a small town or a rural area. And this is even given the fact that compared to their urban counterparts, residents in rural areas are older, poorer, and sicker. There are heightened disparities in rural healthcare outcomes, especially amongst racial minorities, with a particular poor health outcome association amongst rural American Indian and Alaska Native populations. Now, you can look at this slide, but the scope of my talk is not to talk about healthcare disparities and the overlay of race, and that I think I'm hoping in this room I don't need to convince you that there is that dynamic at play across the United States, but in particular, when you have the overlay of rurality and being American Indian or Alaska Native, your health disparities go up dramatically. So for me, now being in a state that's very rural, and also in a state that has a surrounding population of many American Indian tribes and reservations, I started to think about, well, what is it that I do in global health, and what sort of opportunity could that have to help us form a global health program? In 2014, together with some colleagues, we came together and we wanted to design a fellowship that addressed some of these local disparities and link them with what we were doing internationally. And we started what's called the Global Rural and Underserved Child Health Program, and within that program designed a pediatric fellowship. The goals and mission of this fellowship were to provide high quality and sustainable pediatric care in collaboration with our partners, to elucidate common principles in the care of children in underserved communities, and to demonstrate the feasibility of a sustainable global health program that integrates partnerships domestically and internationally. And for us, we thought that we had a unique opportunity, given where we sit and the number of reservations or nations within nations that surround us, to incorporate potentially to address or try to address or partner to address some of the healthcare disparities that we know exist in Native American populations. Now, there are stories and then there's reality, and often those two things don't really match up, and I think this time of year is a time to think about that with Thanksgiving coming. And it's a particularly problematic time to think about this. Manifest destiny and the march of continentalism has decimated North American Indian populations through warfare, disease, forced assimilation, and what can only be described as genocide. I am not the right person to go over this in detail, but I think it's important that we just recognize that there is a historical context to these healthcare disparities. The relationship between the U.S. federal government and the various American Indian and Alaska Native tribes has been complex and fraught with conflict, pain, and suffering, and, like slavery and institutional racism, it's a stain on our history. And I think it's important that we just acknowledge that that's the case. But even if imperfectly doing so, out of that painful history, there has also been a history of recognition that we, as a country, have an obligation towards those sovereign nations that remain. And there's a strong historical and legal precedent for the U.S. federal government providing services and resources to American Indian and Alaska Native tribes. The idea of a trust and responsibility dates back to the founding of our nation, and there are several examples of how we've tried to do this, and even though we've stumbled at times to do this, the principles are still there. One of these concrete examples is the Indian Health Service. That I know you all have sort of a relationship in Shiprock, is that right? In Shiprock, Arizona?
We do.
You do, okay. So has anybody been to Shiprock before? Okay, great. All right. So Shiprock is a service unit on the Navajo Reservation, and it is part of the Indian Health Service. So the Indian Health Service had funds authorized to it starting back in 1921, and has sort of evolved over time, and has gone from a complete federal funding to some more autonomy to individual tribes on how they use the funding from the federal government to provide the health care for members of their tribe. But the overall mission of the IHS is to raise the physical, mental, and social and spiritual health of American Indians and Alaska Natives to the highest level. Now, I know many people who work in IHS, and the people, both administrators and the physicians, are incredible, with rare exception. But funding, again, being a theme that comes up frequently, has led to continued disparities. If you look at across the United States what the funding is, and you compare that to funding to what per capita spending is in the United States and what VA spending is, there is significantly less money spent per patient for IHS patients or for American Indian and Alaska Native patients than for the average per patient spending across the nation. So, and it's not subtle, $2,000 per patient versus almost 11,000. So there's still disparities that persist. And the disparities in terms of the social determinants are quite stark as well. If you look at the poverty rates and the unemployment rates amongst the Native American population, together with who has plumbing in their house, kitchen facilities. So the disparities, as evidenced by markers of social determinants, remain as well. If you look at actual numbers of mortality rates amongst American Indian and Alaska Native tribe members, there's significant differences in mortalities related to accidents, diabetes, alcohol-induced mortality rate, chronic liver disease, and then violent deaths as well, homicide and suicide. Particularly when it comes to suicide, there is a increasing epidemic of suicide amongst American Indian people, and it is something that has been raised as a particular urgent need. One of our fellows has actually worked on this in identification, in a more culturally sensitive way, identification of suicidality, but it's hard to look at these numbers and not be alarmed at the prevalence of suicidality amongst American Indian tribes. With improvements in infant, neonatal, and postnatal mortality, that improvement has not been universally felt across all ethnic backgrounds. You can see that infant mortality rates amongst American Indian and Alaska Natives is significantly higher than white, Asian or Pacific Islander or Hispanic, and then African American, of course, not of course, but African American, you can see, is quite high as well. So improvements in infant mortality have not been felt universally. So all of these, you can see that there are an enormity of health disparities that exist in this population. And despite that, the Indian Health Service, who's tasked to take care of this group of people, has not only been underfunded, but they have difficulty in maintaining adequate staffing in many of these places. So why might you think that they might have difficulty staffing some of these places? What do you think?
Probably a larger rate of patients to doctor, so they have a lot of responsibilities.
All right. Okay. What else? What do you think?
I mean, the pay is certainly not as competitive as other hospital systems.
Yeah. And the pay is, I think there may be a pay discrepancy, but they actually pay relatively good. It's not a bad living. What else do you think?
Undesirable places to live.
Right. I mean, you look back at the slide I gave about 2.5% of MD graduates are planning to work in a rural area. So there's rural, and then there's like Native American rural. I mean, it's like super rural, right? And I don't know if you've been to Shiprock. It doesn't feel like you're driving into Chicago when you drive into Shiprock, right? And we work in a place called Chinle, and you drive in there and you're like, where is everybody? It's really quite rural. So I think the leap for many MD graduates or physicians to say, yeah, I'm going to live in a super rural area is hard. It's a hard lift recruitment-wise. So what happens is they have about a consistent 20% vacancy in their staffing at IHS. So what do? They rely on locums or contracting agencies to fill those positions. Locums and contracting, they basically are like headhunters. They go and they look for people who are willing to fill like a 3-month, 2-month, 6-month, 1-year gap in clinical staff. And doing that is administratively and logistically burdensome for the on-the-ground people trying to fill their gaps. There's also variable quality of who the locums agencies are able to find. If somebody is mid-career and, doesn't have a job and is living somewhere out, there might be a reason why they don't have a job, right? And I'm not saying that's always the case. Some locums are fantastic, but there's a vetting process for locums that's difficult to try to figure out, was this person going to be good or are they not going to be good? And then it's expensive. Locums agencies are for profit generally, and they are taking a cut, and it's more expensive to hire a locum than it is to hire a permanent staff member. So these are all problems that come with difficulty staffing. So, again, we kind of looked at this and thought, well, is there an opportunity here to think about the logistics of what we want to do at the University of Utah and maybe combine some of the global health principles for something here locally as well. It just so happened that somebody in our department had been the chair of the Department of Pediatrics at one of the service units on the Navajo Nation. So the Navajo Nation sits in the southeast corner of Utah, and then borders in the Four Corners area. And my colleague David Sandweiss had worked on the Navajo Reservation for 5 years, and while I won't give you all of the details, but we sort of put the pieces together and we said, hey, we should go down there and see if they'd be interested in working with us. And so he and I got in our car and we drove down there, and what resulted has been a collaboration between the Chinle Service Unit of the Navajo Area Indian Health and the University of Utah's Global Rural and Underserved Child Health Program. And what we pitched to them as an idea is, you have this issue where you're trying to cover clinical gaps and trying to work through for-profit locums agencies to fill your gaps. Why don't you work with us as a university? We will provide you with a 1.0 full-time equivalent, or FTE, of a pediatrician. We'll do the vetting process. We'll recruit the best people we can, These will be physicians who are done with residency and are either board eligible or board certified to practice independently. And we'll give them to you to fill one of your clinical gaps. And then you, Chin Lee, will pay us as a contractor, similar as what you would do with a locums or a for-profit contracting agency, but we'll charge you less money and we'll give you a better product, basically. And they said, that sounds great. Yeah, we'll do that. Even though some years they don't need to hire a contractor, they said, we have to do it enough that we'll do this with you. We'll enter into a contract. And so we've been doing that since 2015, and we are still doing it today. What we also offered to them, and something that was, I think, appealing when we went down and made this pitch, was that in addition to getting that clinical service coverage, this will be an on-the-ground person, 12 months a year, that provides an academic affiliation with one of your neighbors. I think, you know, there are different institutions that work on the Navajo reservation, but we are in their backyard, right? And that academic affiliation was really appealing to the Chin Lee service unit. What that's led to is we now provide adjunct faculty positions for the docs down in Chin Lee. We have started a tele-CME series for the pediatricians that started in Chin Lee and is now happening across the reservation, where they give us topics that they are interested in, and we do the sort of telemagic and provide a CME course for them on management of type 2 diabetes in adolescents, which is a real problem there. We did a tele-CME on identification of child abuse and so on and so on. So that academic affiliation has led to things beyond just provision of clinical care. And then the other thing that they saw and we see as our mission is addressing the pipeline of future IHS employees. So again, it's hard to make the cognitive leap if you've grown up in Massachusetts and then you've gone to UMass for med school and then you did residency at Tufts or whatever, to think, yeah, I'm going to move to southeastern Utah to work. That's a difficult cognitive leap. But what we think is that if we can just bring people out, that they'll like it, and I think what the Navajo Area Indian Health has sort of bought into as well is that they have confidence in themselves. They know that they're doing a good job, and they know that the surroundings are appealing for people as well. And it might be a little less of a cognitive leap for people to say, hey, I'll go and do a fellowship through the University of Utah and go work down in Chin Lee, than to sort of jump into a full-time job right off the bat. And this has proven true for us. We have our pediatrician who works down there, but we have residents who have now been doing rotations attached to our fellow. And we have several residents who now want to go work for IHS when they're done with their training. And so addressing the sort of the pipeline to IHS has been something that's been in our minds, is something we want to do. Beyond that, also, we have this year started trying to link with undergraduates who are Native American and interested in health sciences. So recruitment of actual American Indian medical students to try to get them into medical school. A whole separate talk can be given about the disparities of Native people in medicine. There's not a lot, and not a very effective mechanism to recruit. And so we have tried to enter into that space a little bit as well. So we've partnered with the University of Utah's Native Student Association. We have an application process for 2 undergraduate students interested in medicine. And this year, Justin and Lisa, both of who are Navajo, and interested in going into the healthcare field. Lisa actually wants to do a psychology PhD, but Justin wants to go to medical school. They spent a couple weeks with our doc down in Chin Lee, and it was like better than we could have imagined. It went incredibly well for them to hear their like narrative essay on what their experience was. It was incredible, and I think also for the nursing staff, most of whom are Navajo, and for the administration of the hospital, to see that we were also invested in the pipeline of Native students coming up, I think was a big win for our program as well. And we plan to expand this dramatically next year. We have funding to do so, so we're excited about that. So I think we talked about this a little bit. You know, this all sounds great, so why wouldn't somebody just go work for IHS out of residency? Well, we talked about the cognitive leap a little bit to go work in a hyper-rural area, in a culturally distinct area that you don't know about. And ironically, I think sometimes it's easier for people to say and to have a desire to say, well, I'm not sure I want to go work in Chinle, but I'll go work in Tanzania, you know? So, and I was the same way, right? I came out of residency and I went to Malawi, right? And so there's a desire, and I think it's a good desire amongst trainees and young physicians to work internationally too. And so we thought that this programmatically that we could link this desire and use that as a recruiting tool too, and linking the principles of global health both locally and internationally. We had a physician who was one of my mentors who had worked for HRH in Rwanda. And of course, I had experience working on the continent before, but through his connection, we thought that Rwanda might be another linking partner for this fellowship. And you know, there are some similarities too. Rwanda is a nation that's full of hope right now, but has a devastating history in many ways, and has emerged from the ashes of genocide to be a leader in health delivery, and is in many ways a shining star on the continent. And so we thought this would be another good partner. It's a place where there's a lot of hope, and there is a robust university system there that is invested in both provision of high quality care and scholarship. So we went through the process of making connections in Rwanda as well, and ultimately have now formed sort of this tripartite relationship between the Chinle Service Unit on Navajo Area Indian Health, the University of Rwanda, and our program at the University of Utah. So what does this look like? What does this partnership look like, and how does it make it work? I mean, what I promised you at the beginning of this was that I was going to give you an idea of a sustainable partnership and that linked domestic and global, domestic and international partnerships. So the way it works, I'm not going to bore you. I promise I only have one slide on this, but I think the nuts and bolts are important. Our pediatric fellowship is 2 years. We hire pediatricians, we call them fellows, Global Rural Underserved Child Health Fellows, who split their time between Chinle, they spend 6 months of their 2 years there, and during that time they make money, and that money comes into our program. They spend another 6 months actually in Salt Lake City, and they work in our observation or short stay unit in the emergency room, and they make money there too. And but in addition to seeing patients clinically, they are involved in the education of our residents in our pediatric global health track within our residency. They are engaged like a U.S.-based global health academician while they're in Salt Lake City. And then they spend 12 months of the 2 years in Rwanda. And that's how they spend their time. They also have time to get a master's in global health through the London School of Hygiene and Tropical Medicine. They have formal learning objectives. They're engaged in scholarship. All of them are involved in research. But you guys all know how to do that well. You do it frankly better than we do. But what we have done is designed a program that is self-sustaining. It's not reliant on grants or a donor or a funder. All those things can be fickle, and they're important to have. And in fact, I need to be better at going after some of those grants and funders. But this is a self-sustaining program that, as long as we are seeing patients, then we have the funding to do so. And over 5 years, we're going on our fifth year, we've been in the black financially the whole time. We not only have funding to pay their fellow salary, it's a fellow salary, but we also have money to pay for the programmatic cost, travel, things like that. Now, growth is exciting, but growth can also bring new challenges, and Melissa and I have been talking about some of those challenges as we've grown, and we probably aren't going to be able to rely completely on our revenue generation as we grow into more program development and research. But for now, this has been a program that's worked really well for us, and that logistical challenge, we turned it into an opportunity, and we have sort of addressed the philosophical question as well about what is global health, and we're doing it both locally and internationally. Now, I'd be remiss if I didn't mention also that we're not the only people doing this. Some of you may be familiar with the HEAL initiative out of UCSF, and Dr. Lay, or Fook Lay, is a friend of mine. They have a program that's quite similar in programmatic design to what we do. He and I talk frequently about our similarities and our differences, and he's actually spun off a nonprofit locums agency that's not affiliated with a university called ARC Health, and we are, as a university, the University of Utah is looking to partner with ARC Health in identification of new funding sites, IHS funding sites. But there are other people thinking in this space, and I think it comes out of both those philosophical and just logistical questions. Our fellows, what I know is that they are highly engaged in clinical care education and scholarship. And these are our current fellows engaged in the different projects that we have going on. And we have been so fortunate to be able to recruit just amazing physicians. I mean, our 4 fellows currently and our fellows past, and I'm sure those in this room who have been mentors as well probably could say the same about their fellows. They are the lifeblood of what we do. Their energy, their intellect, their drive. It's really, for me, it's the highlight of my career to be able to work with them. And what I'm proud of is that we come back to our mission, which is to provide high quality care. Our physicians are engaged in provision of the highest quality care that they can in the environments that they're in, and I believe that they have improved the care with our partner sites as well. They are actively asking questions, both systematically and just in their quiet pondering moments, about what are the common principles I see here between Chinle and Rwanda and even in Salt Lake City. I think, heavens, like Salt Lake City might be the most culturally distinct place for them out of all 3 places. But they're asking and seeing those things in Salt Lake as well. And then, we've talked about this before, but it's sort of proud that we've been able to demonstrate the financial feasibility of a program like this. Really, our principles were this. Number 1, identify a local partner with an underserved clinical need and that has state or federal funding. And then 2, partner with them to meet the clinical need and to try to leverage those existing funds to further a global health program. And really, that's it, right? That's the program that we built, and those are the principles that we based it off of. So can that work other places? Well, there is a lot of federal funding out there to meet clinical need, underserved clinical need. And this is a map of the state of Utah. This is the southeastern part of the state, and these little dots are federally funded sites, just in this one congressional district. This website, for whatever reason, breaks this down by congressional districts. And in southeastern Utah, there's one organization in 4 different federally funded sites. This town down here is called Blanding, Utah. So this principle of identifying unmet clinical need with federal funding and state funding, well, we thought maybe we could replicate this. So the state of Utah has actually dedicated funds for programs to send residents to rural locations. So we tapped into some of that money, and now we send our residents to rotate in these sites, and for every resident we send, the state of Utah gives us money, and their interest is to recruit rural physicians, and our interest is, heck, we'll take your money if you're going to do it, and this is actually fits within our mission. So we've replicated that principle with our residency program. Second, in conversations with these docs down here, what they really needed was an OBGYN to come down and operate on their patients who were a little bit too complicated to have surgery by a family medicine doc, but not quite complicated enough to get transferred all the way up to Salt Lake City. So we're working on coordinating with our Department of Obstetrics and Gynecology to send a surgeon, an OB surgeon, down to Blanding once per month to do cases and then to have follow-up clinic the next day. The funding that these sites have, the federal funding, will go to pay the Department of OBGYN at the University of Utah, who will then take that funding and invest it back into their global programming. Because similar to our department, they have residents and they have fellows who are interested in global health. So this is an example of using these principles in a different way. And Utah's not the only state who has federally funded health center organizations. We have 13. North Carolina has 40. There's 40 federally funded health center organizations. Now, there will be differences in all of those, but the principle being there are unmet clinical needs locally. And a lot of those have funding attached to them. And this isn't, this is not a money-making scheme, but it is a way to think about how do you address these philosophical and logistical questions and make them opportunities rather than just seeing them as challenges. And I think that there is opportunity to do so and fulfill your mission and enhance the field of global health in doing so. To end, I just wanted to talk about one of my current fellows. So Anik, who is right here, this is a first-generation immigrant from India, grew up largely in Missouri, did his training, went to undergrad, med school, and residency all in Missouri, and then came to Utah for his fellowship. And during his time, he has become, sort of one of the most favorite doctors down in Chinle. They gave him a cowboy hat. He went to a rodeo, and just fell in love with the place where he was in Chinle. Never would have thought he would be there. Similarly, has spent a significant amount of time at the University of Rwanda at the teaching hospital there, and has both fell in love and had people fall in love with him as well. Because really we are like islands in a sea, separate on the surface, but we are connected in the deep. There are more similarities in the care of children and patients in underrepresented communities than there are differences. And I think thinking about ways to design programs to elucidate those and to think about the sustainability of those is important. Thank you very much for letting me come here. I'm open to some questions. Would love to entertain some questions.
Wonderful talk. Thank you. The parallels between how things are being done in global health in Rwanda or Sri Lanka or Tanzania and how they're being done in Chile are striking. And it just brings to mind for me the challenges of kind of having research and an academic kind of scholarship in places like Blantyre or Lilongwe, where it's been done to some extent in some places like Blantyre and Bamako have done it fairly well. But I can only imagine the clinical burden is so dire in Chinle that it can be difficult to have any kind of a research component. So I'm just wondering, especially not so much for the fellows, but the folks who come down and work in the IHS, do they maintain any kind of an academic affiliation with the University of Utah?
Yeah.
And are there opportunities or aspirational thoughts about kind of integrating research
Yes.
into that experience?
It's a really, really good question. It's been something that we've actually struggled with. I think the clinical burden in Chinle is one aspect of it. I mean, they're working full-time clinically. They take call, they do inpatient, they deliver babies. I mean, they do it all. But I think there's also an element of doing research at an IHS site that has historical complexity because there's a reluctance to allow people to come and do research. There's been, unfortunately, some bad history of people just coming to do research. So I think, we've done some process improvement and system strengthening research where the data is fed back into the process, but certainly nothing on the scale of sort of classic research. However, we've been there for 5 years now, and I think people realize that we're not just sort of parachuting in to take their data. And so those wheels are starting to turn. There's definitely a desire on my part and on my fellows' part to do research. Doing so in a way that doesn't turn people off locally is important. They have, there's a specific IRB on the Navajo Nation that is notoriously difficult, I've heard. But we have there's an asthma study, an NIH-funded asthma study happening right now across the reservation that we're participating in. My fellow wasn't the PI, but he's actively involved with it. One of my fellows worked with other care providers in an interdisciplinary way to develop a suicide screen that is more culturally relevant, and they've collected some initial data, which has then sort of fed on itself and was picked by the hospital administration, all of whom are Native, as the best quality improvement project for the hospital for the year. And they want to expand that to the different service units on the res. And we are talking about how to collect the data on that, how to present the data. So we are interested in doing that there and trying to be mindful to do it slowly. And but I think it's like it's no different in Tanzania. People in Tanzania want to know that you're invested in the care of the patients, not just in the collection of the data. And sometimes that's hard to get that message across to maybe some higher people in the university, that you can't just go and do research. There has to be a provision of care and a system strengthening component. It can't just be research. Yeah. Yes.
Hi, that was an excellent talk. Thank you so much.
Thank you.
My question is, do you have any challenging health issues in your pediatric patient population there? For example, is there a lot of heavy metal poisoning, for example? And if yes, how do you treat them?
Yeah.
And have you thought about collaborating with groups or even countries where heavy metal poisoning is an issue and finding ways or coming up with some treatments for those patients?
I don't know about heavy metal exposure. I think in Chinle there are certainly infectious diseases that are unique to the native population. Invasive.
Aluminum.
What's that?
High levels of aluminum.
I don't know. I don't know anything about the metals. I'm not sure. But more broadly speaking, there are certainly unique health challenges: invasive, Haemophilus, invasive group A strep. But in terms of heavy metals, I'm not sure. But definitely unique. There are some unique healthcare challenges to the native populations that are frankly understudied. But I think people who practice there recognize that there's something different about, a kid who's Navajo who gets group A strep than maybe a kid who's not Navajo. So, yes.
Thanks, Jeff. Could you go back to your slide with the Chinle logo?
You bet. I can find it. Let's see, it might be easier if I do it this way.
right? So my question is about, the logo has many, many cultural icons,
Mhm.
and yet there's very little reference in your talk to culture.
Sure.
And so I wanted to know how your interaction with the community has perhaps changed the way that you conduct
Yeah.
healthcare, how you deliver healthcare, how you integrate local idioms, DNA idioms of
Sure.
distress and care into the work you do.
Yeah.
Thinking particularly of the work of Lori Alvord, the first DNA Native American woman surgeon.
Sure. Well, I don't work there. So first of all, I would say I don't have, I'm the program coordinator, so I won't stand up here and you know, I didn't include a bunch of culture because I'm not a cultural expert on Navajo culture. But the Navajo people who are there are, and our fellows are very integrated into, you know, home outreach and also there's a traditional healer that works in the hospital in the Chinle service unit. But you know, I don't expect or even want our fellows to be cultural experts in Navajo culture because they never will. But I do expect them to carry with them cultural humility and work with the patients and the physicians that are there. But you know, just like, you know, seeing patients in Salt Lake City, if you don't understand the context for which that patient is coming to the emergency department, you are unlikely to provide high quality care. I think that cultural context has a heightened, is more heightened in an area like Chinle because of the historical context. So it's definitely something we talk about. So our, I think one very small piece of this is at the beginning of their fellowship, we have a sort of an introduction to the fellowship, and we have people from the Navajo Nation come and talk to us and talk to our fellows about, you know, high-level pitfalls that you don't want to fall into. But really, it's more about an attitude of humility and going in and wanting to understand where your patients are coming from. So. Yes.
Again, Jeff, thank you for speaking with us.
Yeah.
I'm curious about the number of fellows that you have per year and the demographic of these fellows.
Sure. Yeah. What do you mean by demographic specifically?
Their background,
Okay.
racial, ethnic background.
Sure. We take 2 fellows per year for 2 years, so we have 4 fellows at any one time. And we are in the process of potentially expanding that this year. So to be determined on whether we're going to do that or not. But our current fellows, we have a woman who is Vietnamese from Canada. She trained at the University of Utah. And we have a fellow from the University of Cincinnati who trained at Cincinnati Children's, who's a Caucasian woman. Anik, you met already. And then Esther Shin is a Korean woman who trained at Yale, med peds at Yale. Our current applicants who we are looking to hire this year, we have 2 who we've that will be offering a job to, one of whom is an African American woman and the other is a Caucasian woman. The African American woman trained at Yale, the other one trained at Wisconsin. So most of them are right out of residency. We did hire, Anik actually had worked for 1 year in between residency, so most of them are coming right out of residency. So they're younger physicians. And you know, we're recruiting nationally. So our current applicants come from all over the place in terms of where they've trained. We have one who's one of our residents, and then we have, you know, from all over, from the East Coast to the West Coast.
All nationals or like Canadians?
So it's a good question. The Canadian and U.S. Yes. Yeah. Yes.
Sort of a related question. I was wondering, what is the thinking behind having 12 months in Rwanda and 6 months in Chinle and then 6 months in Salt Lake? Is that kind of based on the need of the population, or what was the thinking around that?
I think there's, you want to be somewhere where there's the capacity to host you, so it's when you have to, there has to be positions open at the certain places. So Chinle is able to take one of us, Salt Lake able to take one of us. Rwanda is open to as many people as we have, but we always have to have whoever is in a non-revenue generating site, there has to be a partner in a revenue generating site. So that's why we have the 2 in Salt Lake and Chinle and then the 2 in Rwanda. But if Chinle said to us, hey, we'll take 7 of you guys, then we would recruit to give them 7. But they're managing their clinical deficiencies, which they really only need 1 to fill up their gaps. They probably don't need 2.
Jeff, thank you. One more question, sorry.
I just had a quick question. So I know we use task sharing and shifting models in other countries when you have the high burden of disease on health systems. So I was wondering if you foresee this fellowship taking on some type of training of lay people or community health workers to help with, in addition to recruiting more physicians into that.
Absolutely, and we're already doing that. So each of our, it's hard to encapsulate in the time frame what we're doing, and I sort of deliberately didn't go into the different research and system strengthening projects that our fellows are involved in. But one in particular in Rwanda is follow-up of low birth weight infants after they leave the hospital, and addressing high rates of mortality in that cohort after they leave the hospital. And our fellows together have worked on a project to follow up on those patients with, return to hospital precautions and things like that. And they've worked with a cohort of community health workers in Butare or in the district of Butare. And so that's a form of working with a different cadre and task shifting.
States is my question.
In the States, we have not. But that is a hot topic, use of community health workers, particularly in the United States, learning from the experience of community health workers in Africa that's been employed with diabetes in New York. And we've had some discussions in Utah about use of community health workers, but our fellows have not engaged in that yet. But I think it's a great idea. It's sort of the reverse innovation idea, right? On our radar, but we haven't engaged in it yet.
Thank you. Jeff, appreciate you being here.